All right, guys, welcome back to Underground Science. In this video, we'll be talking about anemia of chronic disease, okay? So we already talked about iron deficiency anemia, okay? And so we said that was a microcytic anemia, right? Anemia of chronic disease is the second type of microcytic anemia that we'll be talking about, okay? It's actually important to remember, right, that this can be actually normocytic also, right? So it can be normocytic or microcytic. Um, so the size of the red blood cells early on can be normocytic, but then late stages of anemia of chronic disease, you can have microcytic red blood cells. Okay, so let's go and get started and talk about anemia of chronic disease. So let's talk about the pathophysiology first. So how do you get this, right? It's mostly seen in chronic inflammatory states. Okay. So if you have chronic infections, right, or chronic inflammation, right? So chronic infections like TB, for example, or severe infections, even like endocarditis, for example. So endocarditis, right? Or chronic inflammation, even cancer, right? Like solid tumors can induce a lot of inflammation. So why is inflammation bad? Because inflammation, like cytokines, for example, like interleukin 6, right? And other cytokines can go to your liver and tell your liver, hey, secrete a bunch of hepcidin. Okay, well, why is that bad? Because remember, hepcidin inhibits ferroportin. Where do we have ferroportin? On our on our enterocytes, right? Intestinal cells. So remember, you have your lumen here of your intestine. Then we're going to zoom into an enterocyte here, and then we'll have our bloodstream here. So remember, when iron's ingested, right, in the ferrous state, that iron is taken up via divalent metal not divalent transporters, right? Divalent metal transporters, right? Like DMT1, for example. Then that iron is goes from your enterocytes to your bloodstream via a channel called ferroportin. Okay. But if you have a lot of hepcidin, this channel is going to be heavily inhibited, which means you won't be able to get iron from your intestinal cells to your blood. Okay, so you're gonna have a low serum iron. And in your macrophages, right, in your bone marrow, for example, you also have ferroportin, right, which takes iron and brings it out, and especially to your in your red bone marrow, right, where you secrete or where you make red blood cells, and you need iron to do that. But if this channel again is heavily inhibited, right, your macrophages will store that iron in the form of ferritin. Okay, and then you won't be able to have enough iron release, right, especially in your bone marrow, right, your bone marrow macrophages, so that you won't that means you won't be able to make proper amount of red blood cells, also contributing to anemia. All right, so now that we're familiar with that, right, let's go back to what we have. So we said any chronic inflammatory state or cancer, right, solid tumors or chronic infections can lead to the release of acute phase reactants by the liver, one of those being hepcidin. If you produce a lot of hepcidin, right, then that inhibits ferroportin, as we said. So your intestinal cells, right, don't put iron into your blood, right? Instead, you store that iron. So you see elevated ferritin levels in anemia of chronic disease because you have a lot of stored iron because you can't put that iron into the blood. And your bone marrow macrophages, for example, also can't take the iron and put it out and give it to your developing red blood cells, right, in your red bone marrow. So then you don't produce adequate level of red blood cells. So this can also contribute, and then so if your macrophages don't release iron, they can also store it in the form of ferritin, which also contributes to the elevated ferritin levels, right? Which is what you see in an anemia of chronic disease. So again, the cytokines released from chronic inflammation or infection, right, or tumors, not only does it not only does it stimulate your liver to release hepcidin, it also suppresses EPO production, right? Erythropoietin. Who produces erythropoietin? Your kidneys. But if you have a lot of inflammation like this, you can suppress EPO production, and that reduces red blood cell production, remember? Because why? EPO is needed to produce red blood cells in your bone marrow. If you inhibit production of EPO, then you decrease production of red blood cells. Okay, so that's important to keep in mind when talking about anemia. All right, so So let's go on and see what we have next. So let's talk about the labs now that we have a general idea of what anemia of chronic disease is. Okay, again, you have a lot of inflammation, right, due to some sort of infection or autoimmune disease like rheumatoid arthritis or lupus, right, or some sort of chronic infection like TB, or some sort of tumor, right? Like colon cancer, for example, or a tumor in your colon or a tumor in your lungs, right? Or some sort of chronic infection like we talked about, like TB or even osteomyelitis, right? Anything that increases inflammation greatly, right, will trigger your liver to make hepcidin. Hepcidin will severely inhibit ferroportin so that the iron stays in your enterocytes and in your tissue in your cells, right? Like in your macrophages. Okay. So then if iron is inside your cells, like your macrophages or your intestinal cells, right? Or stored inside your hepatocytes, because your liver also stores iron in the form of ferritin, then you won't have iron in your bloodstream. So that's why you can expect a low serum iron because you're storing all that iron. You're not able to release it in your bloodstream because of the inhibition of ferroportin, right? So if you have low serum iron because you're storing a bunch, right, inside your cells, well, what remember, ferritin, right, is the stored form of iron. So we just said we're storing a lot, right? So that means you have high ferritin levels, okay? And if you're storing a lot of iron in your cells, right, it wouldn't make sense for transferrin to take iron and bring it to your cells, right, to your tissue, because you already have a lot of iron in your tissue in the form of ferritin, right? So that means transferrin levels we can expect to be low. So low TIBC makes sense. And remember, you're storing all your iron inside your cells. So there's low serum iron. If there's low serum iron, there's not much iron to bind to transferrin. So you can see a low transferrin saturation. All right. So these are main labs to keep in mind. Now, remember, we said if you have low serum iron, then you don't have enough iron for your red blood cells to have adequate amounts of hemoglobin in them. So your hemoglobin synthesis can be low, right? Because if remember your bone marrow macrophages release iron so that your developing red blood cells, right, can make adequate amounts of hemoglobin. But we said in anemia of chronic disease, you're storing all that iron. So your bone marrow macrophages are storing that iron and not releasing it. So that means your developing red blood cells don't have enough iron to make enough heme. Therefore, they can't make adequate hemoglobin. So you can see a low hemoglobin level, right, due to the low serum iron. Remember, we said that early on you can have normal acidic anemia. So your MCV can be normal, right, from 80 to 100. But later on, it can become microcytic, which is less than 80 femtoliters, right? And you can have a low reticulocyte count, right? Why would you have a low reticulocyte count? Well, remember, all this inflammation also suppresses, right, EPO. And EPO is important for the production of red blood cells. Okay, but if you don't have enough EPO, you can't produce adequate amount of red blood cells, so you can expect a low reticulocyte count. All right, and then when we compare red cell distribution with, remember in iron deficiency anemia, we said the RDW was high, right? But in anemia of chronic disease, it's most likely that the RDW will be normal. Okay, so that's important to keep in mind also. All right. So low hemoglobin, high ferritin, low TIBC, low serum iron, low transferrin saturation, normal RDW, and a normal or low MCV. Okay, that should give you an idea about anemia of chronic disease. Of course, with the history of any chronic inflammation, cancer, or chronic infection, or autoimmune disease, should also clue you in to the patient having anemia of chronic disease along with the lab findings. Okay. So again, things like osteomyelitis or chronic kidney disease, even, right? So if you have chronic kidney disease, remember who produces EPO or erythropoietin, right? Your kidneys produce erythropoietin. So if someone has some sort of chronic inflammation or autoimmune disease where they're producing a lot of hepcidin, so that means they're storing a lot of iron inside their cells, right? Then that means you're going to have low serum iron. Okay, but on top of that, if they have chronic kidney disease, they're not able to make EPO, right? So then not only do they have low serum iron, right? Because they're storing iron in their cells, they also don't have enough EPO production, so they can't make adequate amount of red blood cells in their bone marrow. Okay, so that's important to consider too. So low EPO plus inflammation, right, can lead to anemia of chronic disease with a lower production of red blood cells. Okay, and autoimmune diseases, as you mentioned, like rheumatoid arthritis, lupus, right? Even inflammatory bowel diseases like ulcerative colitis or Crohn's disease, right? All that can increase inflammation a lot, right? Increase can lead to the increase in cytokine production, right? And then of course, which means that you'll have more acute phase reactants produced by the liver, like hepcidin, leading to anemia of chronic disease, right? Even vasculitis, as we know, can increase overall inflammation. All right, so if you did a peripheral blood smear, right, in a patient with anemia of chronic disease, you would see normocytic. You could see normocytic red blood cells, especially early on, but later, right in the late stage, you can see microcytic red blood cells. All right, and then of course you can have mild hypochromia because why? Right? Because you don't have adequate, right, production. You don't have adequate serum iron levels, which means you don't have adequate production of hemoglobin, right? But it's not as bad as iron deficiency anemia, right? So you can see mild hyperchromia, okay? And or mildly hypochromic red blood cells is what we should say to be more specific. All right. So then if we compare the two that we've done so far for microcytic anemia, right? Iron deficiency anemia versus anemia of chronic disease. If we just state it here real quick, iron deficiency anemia, when you look at the ferritin, right, it's really low, okay, because you don't have any iron to store, right? So ferritin levels are really low. But anemia of chronic disease, that's the problem is that you have too much stored iron, okay, because you can't release it because of high hepcidin levels. So then your ferritin levels are high in anemia of chronic disease, right? So in iron deficiency anemia versus anemia of chronic disease, your ferritin levels, right? So ferritin is really low, but in anemia of chronic disease, it's elevated, right? TIBC is elevated in anemia of chronic disease, but low in anemia of chronic disease. And then serum iron is low in both, right? That's why it's anemia. So it's low in both. And then percent saturation or percent transferrin saturation, right, is low in both also because you have low serum iron. Okay, but hepcidin, of course, is low. If we talk about hepcidin, it's actually low in iron deficiency anemia because you want more iron in your bloodstream. So you'd want low hepcidin so you can stimulate, so you don't inhibit ferroportin. That way you can get iron into your bloodstream. But due to chronic inflammation, autoimmune diseases, and etc., and anemia of chronic disease, your hepcidin levels are way too high, which is why you're storing too much iron and not releasing it right into your bloodstream and not releasing it into your red bone marrow, so you're not producing enough red blood cells. Okay, so hepcidin is high in iron and anemia of chronic disease. And then we said the red cell distribution width in iron deficiency anemia is high, but it's relatively normal in anemia of chronic disease. Okay, so that's basically it, right? One thing to know, right, for the treatment. So let's actually go to the treatment. So one thing to know for the treatment, of course, you want to treat the underlying cause first. So if they have a severe infection caused by certain bacterial pathogens, you want to give antibiotics for that so you can lower the inflammation, lower the hepcidin production, right? If they have some sort of autoimmune disease like rheumatoid arthritis, you'd want to inhibit the cytokine release, right? Inhibit cytokines, inhibit overall inflammation, which will help lower hepcidin production from the liver, right? Which will help lower the inhibition of ferroportin, which can increase the serum iron, okay, which can help in the production of adequate levels of hemoglobin. And then just remember, if you have a chronic kidney disease patient along with some sort of chronic inflammation, remember that not only are they producing a lot of hepcidin, so they have anemia of chronic disease, they also can't produce much EPO, so they're not making enough red blood cells. Okay, so you want to give them EPO, right? Plus lower whatever's causing their anemia of chronic disease. All right, but something to remember, right, is oral iron versus IV iron as a treatment in these patients. So because in anemia of chronic disease you have a lot of stored iron, right? So your ferritin levels are super high. And if you give And remember, in these patients, their hepcidin levels are elevated, right? So their ferroportin is inhibited. So if you give oral iron, right, in hopes of replenishing their serum iron levels, because remember their serum iron levels are low, if you give oral iron, right, remember that may be ineffective, okay, because they have a lot of hepcidin in their blood, right? They have a lot of hepcidin secretion from the liver, and hepcidin is inhibiting the crap out of ferroportin. So if you give oral iron, right? So remember, this is your lumen of your intestine, right? If you just draw it real quick, this is zoomed up enterocyte, and then this is your bloodstream, right? So remember, right here is where ferroportin is because iron, right, comes in, gets absorbed through a divalent metal transporter, right? DMT1, and then it gets brought through into your blood via ferroportin. But people and in patients with anemia of chronic disease, you have a lot of hepcidin, which inhibits ferroportin. So if you're trying to give oral iron, right, that may be ineffective because even if you're giving a lot of oral iron, right, you have a lot of iron here, even though you have a lot of iron in your GI tract, you can't really absorb it, right, because your ferroportin's inhibited. So you may need to give IV iron. Okay, so that's something to consider. Okay, unless you can give oral iron, unless if the hepcidin levels drop, right? So if you treat the underlying cause, and inflammation goes down, hepcidin levels go down, you decrease inhibition of ferroportin, then oral iron may work, right? Because then you can actually absorb iron into your bloodstream. All right. So that's anemia of chronic disease. All right. I hope this video wasn't too confusing. Hopefully this video helped a little bit. Thank you guys for watching and see you guys in my future videos.